Very important consideration to keep in mind is the way that we fixate the scapula up against the rib cage, all right? So if we're looking from the front side, this would be a rib cage. If you look at this, we have this entire arm, this entire complex of your arm, really is only attached to the actual skeleton through this little S-shaped bone called the clavicle. It doesn't offer much support, especially if you look at how it's attaching kind of at the end. So what we rely on is a group of muscles, we call them parascapular muscles, and we have about 17 of them that all function to work collectively to kind of help fixate the scapula up against the rib cage. Now keep in mind, this scapula has to move in 10 different directions. What do we have? We have upward rotation, we have downward rotation. We have a very common motion called protraction, we have retraction, right? We also have a little bit of true abduction and true adduction. Then we have straight elevation and depression. And then, of course, one that most of us don't really think about is if you look at the scapula also has an anterior posterior tilt. It can move as much as 20 to 40 degrees. And that's absolutely critical in movement. So, for example, if I hunch over and really kind of create a lot of thoracic kyphosis, and I try and take my arm up, I kind of get stuck. But all I need to do is extend my spine, and my arm can extend almost overhead. How's that happening? Because when I was trying to take my arm up, and my spine was kind of rounded over, my scapula was trying to tilt backwards because that's what happens as we take our arm up overhead. But because my spine was rounded, the inferior portion of the scapula, as it was trying to fall backwards, it was starting to hit against the rib cage, and it wasn't allowing the natural motion of the scapula, and that's why you kind of get stuck. It had nothing to do with the actual arm itself, it was the scapula not allowing it to happen. And then as you extended the thoracic spine, you gave space for that scapula to fall backwards, and therefore your arm could go up overhead. You have tons of muscles, but there's 4 very important ones. We call them the fixators, and they kind of form an X. So if we look at it from the back side, the 2 most common dysfunctional positions that we see in the scapula is one is called the protracted or retracted scapula. So in this case, here's your spine. The protracted scapula is where this border right here starts to stick out. So if you look at your scapula, they kind of roll like this. And that's usually a dysfunction between 2 muscles. The rhomboids right here that are not doing their job keeping the scapula back, and the rhomboids are not working with the serratus anterior. So it forms kind of one of these X's. So here's your scapula, all right? The rhomboids are here connected to the spine, and the serratus anterior is here. So that's one line of the X, and that controls the protraction, retraction. And that's a very common one that we can fix. The other part of the X is what we call the pec minor lower traps, because now we're talking about the pec minor, all right, and now the lower trap. So here's that medial border again. So the pec minor is kind of coming over the top right here, right, and the lower traps are kind of putting this. So they form that second X, right? Now, if the pec minor is tight, it's going to actually create an anterior tilt, because your pec minor originates on the 3rd, 4th, and 5th rib, but attaches to the coracoid process, this little bony projection, looks like a little crooked finger on the front of your scapula. And if it's tight, it pulls the scapula down. And that creates a problem, because now we're going to see not just a protracted scapula, but what we call a winged scapula. If you look at the person, the inferior angle of the scapula, which is this bone right here, seems to stick out. So that's very noticeable. So it's not just this side, but now the inferior angle is very noticeable. A lot of people present with that because we're spending our entire lives like this, and the pec minor naturally gets overactive. And so we have a situation where scapula is not just doing that, now it's actually doing this. So now we have that second cross where we have the pec minor that's overactive here, not being balanced with a force couple with the lower traps. So our X pattern becomes rhomboids this way, serratus anterior that way. When they're in balance, you are controlling protraction and retraction. And then we take the other X, which is the pec minor going over the top, and the lower traps. They actually control the anterior posterior tilting. And when that X is in balance, the scapula is in a nice packed position. But ordinarily we don't have that, and we have people that have a lot of dysfunctional positions of their scapula, which means now they go to move, and they're moving from a dysfunctional platform, because the scapula is the platform for the humerus, all right? Just like the floor is the platform for your foot. And the end result is you're going to have some sort of dysfunctional movement, which over time could lead to some overuse and potential injury.